Meredith Cornett, for those of you who can't see me. Really excited to have our very own homegrown speakers today. Healthcare for all Minnesotans. And we believe that healthcare is an essential human need and that unequal access is a moral injustice. Today we're going to learn about important actions each of us can take in the year ahead. We're going to kick off with Tom Starkey, who volunteered to share his knowledge with us today and brought along our other folks, including Rick. How do I pronounce your last name?
Yeomans.
Yeomans. And then I'm going to let you introduce your other co-presenter here. Thank you so much for being here.
Meredith. And the other co-presenter here today is Jerry Whitty. We're both, all three of us are volunteers with Healthcare for All Minnesota. And just to tell you a little bit to start off with about Healthcare for All Minnesota. It's a nonprofit, nonpartisan issue organization. It's dedicated to promoting comprehensive, affordable, high-quality health care for every Minnesotan through advocacy, education, and community organizing. We believe healthcare is an essential human need and that unequal access is an injustice. We believe a financial system with premiums based on ability to pay is the only way to achieve our ultimate goal of a single-payer healthcare system for Minnesota and eventually the whole U.S. Our goal is to unify a state-based movement of committed individuals and organizations to educate and engage Minnesotans on the issue of healthcare reform.
Well, moving to the next slide. My name is Drew. Involved with this seems like forever. I think everybody. But you don't know how that. In Canada, they had got their healthcare system. One province, I mean, state first, and the rest of Canada adapted. The same thing. Good Minnesota, and then the rest of the country. This is Rick Yeomans.
Say hi, Rick.
Hi. You guys, I know most of you. I am probably the most recent. I just glommed down about a year ago with these guys. We do the majority of our work locally at fairs and different whenever there's an opportunity to promote for all Minnesota. We also go once a year to St. Paul and lobby the state legislature, which we will be doing again next month. March 10th, yeah. Everybody wants to pile in the car, come on. But we are continually working on this, and all of our legislators here are supportive of it, so we don't have a whole lot to say to them, but so.
Even though we have support solidarity, this is something that's important. This is important to get. Have solidarity. We've got both representatives on board with this, but still go down there to show that we're here. It means that we want to get this. It's still important, even though we've got.
Okay. Some of the things that we're hoping you'll take away from this presentation. We vastly overpaid for healthcare in the United States, and we're not getting our money's worth. We leave too many out. We do not need to come up with new money to fix this. We already know how to fix it. The solution is fairly simple. The question is not how to fix it, but what's stopping us. We continue to tinker around the margins, and that is just not working. We need to do more. A brief timeline about how we got into this situation. In 1966, when Minnesota implemented medical assistance, it was a relatively simple and was run by the Department of Public Welfare until 1984, when the DPW became DHS, or the Department of Human Services. It was pretty simple compared to today's program, which is so complicated. Can't hardly figure it out. It was a direct payment system where providers would provide a service, doctors, hospitals, and the state would pay them directly. And so we had something direct payment way back in the 60s, all the way up into the 80s, when the Minnesota governor and the legislation decided to turn medical assistance and Minnesota Care into a complex and unnecessary, expensive program. They added HMOs and other MCOs who handle healthcare problems for the state without any real review or evidence that it was reducing money for anyone. In 1996, DHS, in 2010, without asking why HMOs had failed to save money, the legislation authorized DHS to insert another form of HMO, integrated health partnerships, into the programs, a so-called way of testing alternative healthcare delivery systems. The IHP added one more layer of startup and administrative costs, with little research showing any savings, just more. By 2012, medical assistance and Minnesota Care contain not one but two middlemen, HMOs and IHPs beneath. Both layers added together have administrative costs equal to about 15% of total spending. So, recap, and this is kind of, this slide shows what's going on nationally. We pay for health, the way we pay for healthcare in the US, it costs too much, does too little, and leaves too many people out. It consumes over 18% of our GDP, 1/5 of our 29.2 trillion economy. And even with all that money being spent, there's still millions of people in the US who lack health insurance coverage. How do we know the difference between incrementalism and distraction and real progress? Well, real progress lowers or eliminates administrative costs, reduces or eliminates the influence of private insurance, helps build the administrative structure for a needed public plan, make care more affordable for everyone, and removes barriers of cost, provides choice of providers and hospitals, provides comprehensive coverage, cost containment authorities and provisions, avoids use of the managed care tactics, which include deny, delay, and blame. So we've created this system that is way too complex. Most of the providers in the system have consolidated other things into the system, in terms of pharmacies, clinics, and even hospitals. So it's kind of quite a complex system when you look at it on a map. Today in Minnesota, there's roughly, if we're talking just Medicaid or medical assistance, there's 1.2 million people that utilize medical assistance here in the state. Minnesota Care, which is a little separate plan, that covers about 100,000 people. So we have about 1.3 million people who utilize those public services here in the state of Minnesota, to the cost of about $20 billion. I think I'm going to let Jerry talk a little bit about the impact on Minnesota's Medicaid program.
Okay. Well, we're gonna be going to the legislature, but it's have problems with money. We can take this administrative cost of patient-centered care bill. We could take up and back into our budget to pay. This is why we're really pressing to see that PCC bill pass. I don't have it. Okay.
The impacts of the HR1 bill, the big terrible bill that happened back in July, there's been different estimates about how it's going to impact people that are on the Medicaid or medical assistance. Kaiser Family Foundation, a large medical conglomerate, has estimated that about 250,000 Minnesotans will access to health care. 50% of children in rural Minnesota will lose access to health care, and almost 500,000 in federal dollars. These cuts are cumulative and will expand over time. DHS has also put out a report that says everyone in Minnesota is going to pay in one way or another. And it has a little different take in terms of how many will lose health care. Their report came out a little later, and they estimate 140,000 people in Minnesota will lose coverage. But 140,000 people, just imagine that, how many people across the state and how that's going to affect our economy. Just think of 10,000 or 20,000 of those 140,000 people live in Duluth, what that'll do to our healthcare system. One of the things that the HR1 or the great big bill did or tried to address, they wanted to create more working requirements, more eligibility checks. And their thinking was that there's a lot of people that are laying around not working that could be out there working and getting insurance through their employers. Well, the truth of the matter is there's about 92% of the people that are on medical assistance actually are working. They may not be working full-time, or they may be going to school. But the people that aren't working is a very small amount. It's only like 8%. So that's kind of a false narrative. Another group that can be affected are people of color. It's estimated, and again, I think this is from the 65% of Black mothers who rely on Medicaid are now at greater risk of losing it. Hospitals in Black neighborhoods are 4 times more likely to close. And about 1 million people could lose coverage to the HCA tax credits.
You know, seeing this in the news as far as rural health. Rural. Dr. Oz said we're going to use
Who's how many?
they're going to use AI to administer rural health care. Out in the rural areas.
So this slide was a kind of a drawing by somebody that worked for Disney, and it kind of shows our current system and how convoluted it is with all the different consolidations that have occurred and how difficult it can be. And then on top of that, you have these cuts from the mega that are really going to affect how people's care is. It's a very dysfunctional system. And compared to other countries around the world, the U.S. ranks about 37 overall in health outcomes against all other countries in the world. So countries like Cuba and Romania have better healthcare coverage. Health outcomes, population health measures, life expectancy, mortality rates, those kinds of things are all measured by the World Health Organization. The efficiency, equity, and health outcomes aren't very good. We're near the bottom of the list of things as well. The only thing that we do good is we know how to treat specialized cancer, but that doesn't really address overall. In the most recent report using 22 data, the U.S. came in last in 5 outcome measures compared. Well, if we were to look at our spending as far as a country, a nation, our GDP is way up there, close to 18%, where the rest of the world are all the other lines down below. So there's quite a difference, and we could definitely be doing things differently, and we need to.
Well, getting back to the states of care bill, they've done this in Connecticut. Connecticut has saved billions of taxpayer dollars and at the FCC. 2.75% program cost of cost 3.95% compared with the US 8.5 higher from other states. There are other, they're not listed here, but there are other states doing the same thing that are saving tons of money.
Oklahoma tried to do the same thing and did it for a short period of time. And the problem is the politics really influence this issue big time. Country or states like Connecticut and Oklahoma, where they quit their and went back, were influenced because of what was happening politically. Connecticut's been able to survive the politics, and it's working well. And they're saving close to $500 million a year. So if we were to try and do something like the Connecticut model, it would take a little bit to do. One of the things that HCAM has been covering and pushing for a while is the Minnesota Health Plan, which would cover everyone, not just people on medical assistance, and it would cover everything: dental, vision, hearing, mental health, prescriptions, long-term care, alcohol, doctors. There's not as much administrative waste, it's affordable, focus on preventive care, and have enough providers to avoid waiting lines. So those are some of the things that are listed on the Minnesota Health Plan, which would be kind of our long-term goal and a gold standard. And how would it work? We use the existing providers, clinics, hospitals, dentists, physical therapists, pharmacy networks. So we have the infrastructure already built. Families would pay a premium based on their income to the Minnesota Health Plan Fund. Employers would no longer need to offer or provide employee coverage. It would be replaced with a dedicated tax. Providers negotiate rates and compensation. Minnesota Health Plan Board. Hospitals will be provided a global budget based on healthcare needs of their community and a capital needs. All of it would be governed by a Minnesota Health Board, democratically elected. Board administers health systems bound by MHP governing principles and sets the prices, acts to end conflicts of interest. That single payer type system like that would do a few things, would provide freedom, end the corporate restraints on your personal health care decisions, free to choose any doctor, any hospital. Equality, pathway to end racial bias in funding and delivery of care. Progressively paid for comprehensive insurance for everybody in America, regardless of race, ethnicity, income, wealth, and employment. There's there. Security, that's a big one. Always have cradle to grave, regardless of changes in life. So that's the gold standard, the Minnesota Health Plan. And how do we get there? How are we going to get to this all-encompassing system? Well, like Jerry was saying about Connecticut, they are doing something right now with their Medicaid program, their public programs. They've deprivatized, and that could be a start for us here. Deprivatize our program. We don't really have much other choice, especially with what's happened with R1 and rollbacks of funding. Our options are pretty limited. We have to cut eligibility, cut benefits, cut already low reimbursements to providers, raise taxes. But there's another option. We could remove health insurance companies, often called managed care organizations. We're going to go ahead here for patient-centered care.
Well, I did talk a little bit about it earlier, but this will help move the ball down the road. It's where we're going to publicly bid it. And if we can pass this bill, what's that? And we can for the whole state of Minnesota. It's interesting, these big companies that can self-insure, they don't use it. No one. So they self-administer their own health care. This is an unnecessary barrier between the provider.
You notice when we go down this list, so many things are talking about the administrative costs. And over again, administrative costs minimize. One of the biggest things about administrative costs is that you and I are paying the insurance companies for these administrators whose job it is to deny us our benefits. So that's what we're paying for in administrative costs. When we eliminate them, we've eliminated a hurdle, and we can actually get the health care that. So, and in fact, when Jerry's talking here about the healthcare company being gone altogether, what go directly to deal with the provider itself instead of a middleman that does nothing but take the money from them. So that's what we're working.
One of the things that HMOs claim that they are doing is that they do coordination. Well, we kind of reject that idea that HMOs and MCO care coordination. We think that doctors and nurses do that, and we'd like them to do it, only them. And by eliminating the 15% administrative costs from HMOs and getting rid of some money to help do that, pay for it. DHS also funnels extra payments right now through the HMOs to provide collective services, which are the care coordinating things. And we can, like Rick was saying, we can remove them. We don't need that. And right now they're telling doctors basically how to practice. And doctors don't need that. This would be a big help for doctors to get rid of the HMOs. In fact, DHS is currently still using direct payment for treatment of enrollees with disabilities. According to DHS, 17% of all medical assistance, 235 in Minnesota, use direct payment. And so removing the HMOs and their overhead would save roughly $100 million here in Minnesota, used off the upcoming cuts from the federal government. It sounds like too much of a pipe dream. Remember, again, Connecticut is already doing it, saving $500,000 a year, and the state's doing it to 35,000 people a year here. So, plans to enact patient-centered care. Well, the plans that we see, the way we'd like to see it happen with healthcare for all Minnesota, we'd like to see that the Minnesota legislative session in this coming year advance the PCC bill as much as possible. At the minimum, get a hearing in one legislative committee. It's only been introduced. It hasn't had a hearing yet in any committees. Try and get hearings in more than one committee in both the House and the Senate. And I think we'll be able to do that now that HR 1 has rolled out and people see how the federal government is going to be cutting back. The patient-centered care bill is really going to make a lot of sense. If we can't get the bill through in 26, we'd like to work on it between 26 by holding legislative committee and informational hearings and awareness support from our legislators. And then in the 27 legislative session, hopefully we'll have enough support, hearings and votes in all the needed committees at the governor's. So what do we do here locally? How can we have commitments from Senator McEwen, Representatives Johnson and Kozlowski. But what we need to do is really reach out of the Duluth area, outlying areas, and start getting support from Senator Grant Hochschild in Senate District 3, or even Natalie Zalesnikar in the House. She's really an important person. She's not a Democrat, she's a Republican, but we need to reach out to her and push her and get her to stop saying fraud, 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 and explain a little bit about what she is doing. She is on the Health Finance Committee in the Minnesota House. So we need to push her and have her explain to us what her plan is. She's not going to, she doesn't favor the bill. What does she think? And I don't think nobody has an answer for that other than the PCC bill right
now. As far as that goes, my experience on our three and I don't think any of them are in the healthcare, and they take their support them, they'll support the business. But you get these things, willing really listen to your people here. So for me to go over the hospital, to be not as hand thing, but we need people out here who are in those businesses, right? And we are.
Some other things that you can do to help us. One big thing is to get to ask Moose Jaw to get on board to support the patient-centered care direct payment bill. So when you see Kathy Peterson standing right back there, ask her to get on board and talk to the board at Moose Jaw and say, yeah, this is a great idea. There's other groups like Isaiah that have plans out there, but they're not really addressing what's going to happen with people that are on medical assistance. They're more, they're looking at people that were on Minnesota Care or MNsure that that are dealing with vouchers and granted that's important too, but the people at the very, very bottom that are on medical assistance, and everybody here probably knows somebody that's on medical assistance. They really need our help, and we need everyone like Moose Jaw, like Isaiah, like any other organization. We need collaboration to make this happen.
You have
Are
a
you
question?
holding questions to the end?
Yep. We're almost there. So just to wrap it up here real quick, before we get to your questions, here's the problem. Your insurance doesn't cover much, says the doctor, and the patient says, what's covered? Well, why don't you tell me the problem and I'll tell you if it's covered. I'm sick. Nope, not covered. Go ahead, Jerry. Rick, what else you got
They
to
skipped
say?
over that one slide that really is important. Health insurance is not our health care. They are looking to extract profits, and one company alone, United Healthcare, our Minnesota-based company, year after year in profits, billions, 20, 30 billion dollars annually. Not talking about the salaries. That all comes out of our healthcare. Why is it going into paying doctors to take care of us? It's not healthcare.
22.5 and 23.
Okay, so all of this is online, right? The Healthcare for All Minnesota, I don't know if these exact slides are, these are not, but Healthcare for All Minnesota has a website that you can get all of this information on by Googling Healthcare for All Minnesota. It's all out there, it's all public. Talk to people, let them know. So what are your questions? What questions do you have, Tracy?
And I do have a mic here that I can run, and I just want to say a couple things. Well, one thing, I'm represented by House Shield and also by Zalesnik Car, so I can certainly bring this up with them.
So that's a good segue into my question. If this went through, would there still be things like the elderly waiver? Like, Natalie Zalesnikar, I think it's well known, she owns the Diamond Willow chains, right? And, I've called for friends and that's about $18,000 a month. And because it's advanced assisted living, you can die there. But anyway, if you spend down your savings and use up all your money and pay that, your spouse can still stay in the home. They won't take you home. And then you go on an elderly waiver and the state pays everything except $1,000. And I wondered if PCC goes through, does the elderly waiver stay? Then that would help with that.
I've got the bill, I can look it up.
Okay, you don't have to right now. You can email me.
I would say that that's an interesting situation, and I would think that it would cover the person if they were on after they did their spend down, they were probably on medical assistance. So it's supposed to cover everyone that goes on to medical assistance. And even though your spouse might have assets and other things, I don't think that should matter. There's things that are going to be negotiated too that still have to be ironed out, specifics like that.
Sorry, this is just a comment. I would like Minnesota to be the Manitoba of the United States, because can you say that already? I came in late. Did you say that?
Thank you, Tommy Douglas.
Yeah.
Wire rights.
So anyway, could you go back to that slide that showed the top 17 countries in healthcare? And we were at the bottom. Was it Australia at the top? Yeah, right there.
Okay, at the very bottom.
We're at the very bottom.
No, we're at the top.
This is
We're-
what
this
we,
is
this is what we,
GDP.
this is what we spend.
Yeah.
This is what we spend.
Yep.
So
So we spend the most as a country. We're close to 18% of our gross domestic product. GDP.
I'm looking at AUS at the top, but
that's
US
just,
at
it's
the
just a
bottom.
color code.
So I'm looking
Yeah.
at this wrong.
Yeah, AUS is Australia, and if I'm seeing it right, Australia is kind of right in the thick of this, all the other, right in the middle there. So they're spending roughly,
Oh, by color, okay.
Yeah.
All right.
yeah, they're like 9 or 10% of their gross. Yeah,
Who's the best here?
the very best,
Is that Norway or down there?
I think it is either Switzerland down at the bottom.
Switzerland? Oh, sure, Switzerland. In color.
Actually, let's just see here, maybe not. Maybe it's Korea at 8.8%.
Yeah.
South Korea?
South Korea, correct.
So I'm gonna say, could they send us their manual?
Well,
I mean, we do, it still sounds like we're still inventing the wheel. We're piecemealing this thing, like.
it's still the insurance industry. Their motivation is to not spend money and to make money.
Yeah.
Where the motivation should be to make people healthy, preventative care. For preventative care alone would cut our, if you get sick in the first, we've got people who don't go to the doctor when they have insurance because they're afraid that they're going to have to spend some money on
Yeah.
payments just before they go there.
Yeah, the other cultural difference is Teresa and I went to Kazakhstan, and they have free healthcare. Or, I mean, lots of countries have it now, and we found out that you asked the question, well, who's making money around here? And they said between lawyers and school teachers, doctors, that make the most money.
Nails.
And people who are doing fingernails. And thinking, could our today's doctors handle that kind of cultural financial change in their lives?
The thing that surprised me the most is the slide that Tom shared where it stated that we were 34th outcome nations in the world. 37th. 37th. Okay. 37th out of all the countries in the world. I mean, think of what we want is we want to, of course, we want it to be the most affordable and we want the best outcome. And we have the 37th best outcome. That's down there a ways. Isn't it amazing that this developed country ends up 37th?
It is amazing.
How much research we have, how much product development, how qualified the doctors are. And we have those insurance companies standing in the way of us getting that service.
I'm gonna come back to Naomi here, but I do have a question from online, from Barb Avery. State Senator John Marty has worked on single payer healthcare for many years. How would the plan you are discussing compare to his, or is it the same when I miss it?
It is the Marty plan, and I mean, the end result is the plan that he's had out there for a long time. In fact, generally, we have a copy of it with us.
John Marty wrote the book on this. In the book,
Here it is.
it's on my back. Just take a picture of the QR code. It'll take you right to this book, and you can read the book. It's an older book, but it's still, the money is probably.
So part of what I was going to say is in response to Tom, can we get their manual? Yeah, we spend by far the most, we have by far the worst outcomes. And many other developed countries have figured this out. And they've figured it out in different ways. So it's not like we have to be Canada, or we have to be Germany, or we have to be the UK. There are lots of different models for doing this. But what we don't have is the will to do it. And I do think part of that is all of the invested parties, right? The insurance companies give a lot of money, make a lot of political donations. And there are a lot of people with stakes in the system that we have, and we have to figure out how to change that, how to have the voices of the people heard more, and to somehow minimize the damage to other people.
I would say that, you know, by copying what Connecticut has done is as a start, really, really good plan moving forward. And the other thing is, we have to make this an election issue. We have to press our politicians and our candidates on this issue. This is a way that we can get rid of people like Pete Stauber, get him out of Congress, just by talking about what's going to happen or what is happening with the great big ugly bill. You know, we got to make the people pay that did that to us.
I do have comments from online from Arlen, who is in New Orleans right now, and she wants to get in this item. One thing which greatly impacted me on moving back to Duluth after practice as a nurse practitioner in the state of Virginia for 5 years was the independent practice law for nurse practitioners in Minnesota. So, see if I can scroll down here. Nurse practitioners coming from out of state. So sorry, y'all. Having a billing issue. I am going to give the mic here to Will, who had a question, and I'm going to come back to this
Let me make one
comment.
comment first, just to answer that question about, you know, the people. We have elections coming up. Vote for people who don't take healthcare money. And Peggy Flanagan's running for Senate. She's a supporter of healthcare for all Minnesota, a strong proponent of this, and definitely somebody we get behind. But just do a little research, make sure you find out who takes that money from the healthcare system.
I want to finish up our topic. All the people in this country, this state, they're all in support of this. It's about, it's like 68, 80%. It's out there. When it starts slowing down is when the money starts throwing fewer things in. And that's where we got to start standing strong. They're going to say you're going to have delays, like Canada, you have delays. People in here have had surgery. You got the surgery you wanted right away. The sad thing is, in every system, there's delays. That's not an issue. When they start putting back the fear tactics, they've been saying the same things over and over and over again, and they're lies. And we have to stand firm against those lies.
You know, you called out Moose Jaw. Is the MNA behind this?
Gonna let Will get his
I'm sorry. I'm sorry. I'm here.
And then we'll wrap. Obviously, a lot of interest in this topic.
I mean, one can't be impressed, or can't be impressed more by the big investment that's been made in Duluth in our hospitals. And quite frankly, I just never have understood how they get compensated or how it works. Are they going to benefit from single payer, or why wouldn't they? Why wouldn't they want single payer healthcare? How does it work?
That would be a good one. I said a cost job because he works for Ascension.
The model for how to do what we're talking about is during the Franklin Delano Roosevelt presidencies. And so the model of what you're talking about is available. And when And when people like Reagan became president, the wealth began to move upward, fewer and fewer people. So there is a national, or at least we can do it in Minnesota, to equalize the distribution of of wealth in a just way.
Yep, and I think I want to answer, Therese, you had a question about the Minnesota Nurses Association. They are absolutely behind us. Yes.
Sir, the chairman of Healthcare for All Minnesota is Rose Roach. So if anybody knows about the nurses, Rose.
Okay, I'm just gonna read Carlin's comment here since I have Naomi to help me with the mic this time. This is about nurse practitioners in Minnesota. And if they come in from out of state, they cannot practice until they have 2,080 hours of supervision by a physician, regardless of how many years of invaluable experience that they have in another state. This is a big oversight, glitch in the independent practice law, which she's not going into further, but wanted us to be aware of these barriers and to eliminate access barriers to nurse practitioners as their delivery of primary care is cost effective and patient centered. I want to just thank the three of you for this excellent presentation and to all the great questions and comments, as well as the participation online. We've had just great discussion today. I know we should not leave it off here. I feel like I have a to-do item, like when I get home, to talk to my senator and representative in Friedberg Township. And please do come and talk with Tom and Jerry and Rick after the presentation too, because I am sure that there is more discussion to be had. And would greatly appreciate help putting things away if you are moved and able. And I believe that next week we are on for Camp Unistar. I think that will be with us. So look forward to that. And thank you so much for coming and all your help.